Many women with type 1 and type 2 diabetes have sexual problems. In fact, about a third to a quarter of women experience complaints of sexual desire, arousal, and even pain with sexual activity or dyspareunia related to a variety of conditions, including the vulval and vaginal changes associated with menopause and beyond. The most common complaints in women are related to desire and interest in sexual activity, as well as changes in genital sexual arousal or responsiveness and their orgasmic capacity. These problems occur in an age-related manner and sometimes in the context of biopsychosocial factors or physical changes associated with diabetes and diabetic conditions. While there are biologic factors, probably the most important factors in diabetic women affecting their sexuality have to do with their social and relational context, as well as their disease adaptation and their self-image and their feelings about themselves related to diabetes. So for example, being anxious or worried about diabetes management, getting anxious or becoming hypoglycemic during a sexual event, worrying about how the apparatus might impact the way they look toward their partner or their comfort during sexual activity can all be factors. Probably the most important psychological or psychiatric factor is depression and its association with the disease state and its complications. So this is an area for intervention that we could really focus on in our patients. Many of us don't know about these sexual problems in our diabetic patients because they don't raise them spontaneously. Patients, hands down, women, diabetic and otherwise, really prefer the clinician, the healthcare provider, to ask. Now, this may be a little bit awkward, so I recommend that you think about introducing it or giving a warning shot or framing it with something we call a ubiquity statement, such as, many women with diabetes have changes in their sexual function. How about you? Or many women with diabetes notice decreases or differences in lubrication after menopause. Has that affected you? And if a person answers yes, then you want to validate that, as well as ask about other sexual concerns so that you have the full picture. So how is your sex drive? Are you able to get aroused? Do you need more stimulation? Can you reach orgasm? Are you having pain? And then you want to use an open-ended inquiry to allow the individual or encourage the woman to tell you more about the situation and its impact on her own sexual function and its impact on her relationship. Well, there is some research on looking at the biological factors that affect diabetes in general. They affect the neurologic system, vascular, and hormonal systems, and the potential role that these impairments may play on the sexual function of diabetic women. The strongest evidence for lifestyle intervention has to do with improving the psychosocial factors that I mentioned. We can counsel patients to improve cardiovascular risk factors and neurologic function. Exercise, diet, particularly the Mediterranean diet, weight loss, improving physical and sexual self-esteem by being stronger, muscular development, improving bone health. All of these things can have a feed-forward effect on overall body image and self-image, enthusiasm and energy for sex and sexual function specifically. There are a collection of treatments available for women, both in premenopausal and postmenopausal ages, to treat sexual disorders. For sexual desire in premenopausal women and late reproductive age women, there are 2 FDA-approved drugs that both are centrally acting that can help with sexual desire and sexual responsiveness. Flibanserin is a daily on-demand serotonin drug with mixed receptor agonist and antagonistic effects that improves overall sexual desire. Bremelanotide is given on demand and it works through the dopamine melanocortin system and improves sexual receptiveness and responsive sexual desire as an event-related experience. And it's, as I mentioned, it's given on demand, but it has a feed-forward effect in that it overall improves the interest and desire for sex. For diabetic women, there's no specific research on these medications, but they can potentially be helpful in the right populations. We also have a fair amount of evidence supporting the role of androgen or testosterone replacement for postmenopausal women with distressing low sexual desire. And there's no specific research on diabetic women, but also no clear reason why it would be contraindicated with careful monitoring and dose adjustment as would be done in any postmenopausal woman. Finally, as I mentioned, sexual pain related to decreased lubrication and vulvovaginal changes after menopause can significantly affect the sex lives of postmenopausal women. So we want to learn about and treat these changes related to vulvovaginal atrophy and what's called genital urinary syndrome of menopause. We can offer specific non-hormonal changes, such as suggesting lubricants, either oil-based or water-based with sexual activity, recommending moisturizers, which are used on an intermittent basis, like, for example, 2 or 3 times a week to improve overall vaginal moisture, independent of sexual activity. We can also recommend regular sexual activity, which can help improve and condition the vulvovaginal tissue and help condition the elasticity in conjunction with lubricants and moisturizers. For women who don't respond to the non-pharmacologic interventions, such as lubricants and moisturizers, there are an array of low-dose, local, meaning given just on the skin, estrogen products that can be prescribed in a variety of ways. There are creams, inserts, tablets, and a ring. And all of them can really help with reconditioning or resurfacing the vulvovaginal tissue after menopause. They're minimally absorbed, and therefore, although they carry the estrogen class labeling, are thought to be quite safe when it comes to some of the concerns that we have with systemic estrogen therapy. There's also an intravaginal DHEA suppository and an oral SERM that can also be used to treat vulvovaginal atrophy and genital urinary symptoms after menopause. Finally, it's important for us to understand the resources in our community. We can refer to sexual medicine specialists, gynecologists who treat these conditions, particularly have an expertise or an interest in treating vulvovaginal atrophy and improving sexual function. We can refer to psychological counselors. There is some evidence supporting the use of mindfulness-based cognitive behavioral therapy for improving low desire as well as other sexual functions in diabetic and non-diabetic women. And we can refer to psychological and sex therapists as well as couples therapists who can help with the relational and social factors that I mentioned. Also, pelvic floor physical therapists may be helpful for patients dealing with an array of problems related to sexual pain. So in sum, it's important for us to understand when treating our diabetic women that there are an array of biological, psychological, social, and cultural factors that impact sexual function, and behavioral and lifestyle interventions, as well as intervening with these factors that are amenable to intervention on a biological level, can really help our patients. Even if you don't have the time or the specific interest or the capacity in your practice to manage these problems, the most important thing you can do is ask. Patients want you to raise the topic and then identify the problems and figure out who in your community can provide the resources that can offer